Because are we waiting for someone else?
Not exactly, sir. We are here now, and I think we can start. Thank you.
Yeah, I think.
Good morning, everyone. I welcome all of you on behalf of SDGCC Punjab, Sustainable Development Goals Coordination Center Punjab, UNDP, and Department of Planning Punjab to today's conclave focused on United Nations Sustainable Development Goal 3, good health and well-being. I would like to extend a special welcome and thank you to our esteemed dignitaries, Principal Secretary, Health and Family Welfare, Government of Punjab, Principal Secretary, Department of Planning, Government of Punjab.
One request. Please mute, ask everybody to mute because there's a lot of echo. Thank you.
I request all the participants to please mute their mics and please keep them muted throughout the session. If you have any queries, kindly type them in the chat box and we'll take them up. Thank you so much. Thank you. Should I start over, sir, or should I continue?
Nandita, please carry on from where you left. You can start.
Okay. Sorry for the disturbance. As I was saying, I would like to extend a special welcome and thank you to our esteemed dignitaries, Principal Secretary, Department of Health and Family Welfare, Government of Punjab, Principal Secretary, Department of Planning, Government of Punjab, Regional Head, UNDP, North India, Mr. Vikas Verma. We are very thankful to our thematic experts for joining the session and agreeing to provide their valuable inputs to this conclave. Dr. T. Sundaraman, Dr. Pradeep Joshi, Dr. G.B. Singh, and Dr. Rakesh Kumar. We are very thankful to all of you. As we go forward, I would just like to inform everybody that we're recording this session. So thank you for agreeing to do so. And as we said earlier, please mute your mics. And it would be great to see all of you if you could switch on your videos, but it would be great if you could please mute your mics so that we have minimal disturbance. Thank you so much. Without any further ado, may I request Mr. Vikas Verma, Regional Head, North India, UNDP, to kindly welcome all the audience and our esteemed dignitaries. Over to you, sir.
Thank you, Nandita. Thank you so much. And a very good morning to everyone. And on behalf of the UNDP India and SDG Coordination Center Punjab here, I really have the pleasure and privilege of welcoming all our esteemed guests who are present here today. It's so heartwarming to see so many of us here. I would really especially like to extend warm welcome to two chairs in this consultation, Honorable Shri Husan Lalji, Principal Secretary, Department of Health and Family Welfare, Punjab, and Shri Rajkamal Chaudhary, sir, Principal Secretary, Department of Planning, Punjab. And I also extend my welcome to Shri Mangat, Shri Planning, and many other dignitaries and people who will be speaking, Mr. T. Subramaniam, Dr. Pradeep Joshi, Mr. G.B. Singh, Dr. Rajesh Kumarji, and of course, our moderator for the discussion later today, Dr. Manmeet Kaur, Professor, School of Public Health in PGIMR. And of course, all the civil surgeons and other officers for the Department of Health and Family Welfare, faculty of the universities, thematic experts, my colleagues in the Department of Planning, in UNDP, in SDGCC, a really warm welcome. So just to give you a brief introduction as to what we are trying to do today, I think, we've been talking of sustainable development goals, and we've been talking about that since January of 2016. But even now, when we enter the critical decade of action for SDGs, we are still kind of trying to configure how we should integrate with our regular day-to-day work, the SDGs work. And then what happened is our world was hit by COVID-19, which clearly showed to all of us which areas of work we must hasten to address if we have to save the humanity, and health came on top of that. And so that's really no prize for guessing there, because we have been still reeling under that impact. But we must remember, I think that COVID-19 has had, although impact, unprecedented impact, I would say, on societies, the livelihoods of communities and well-being of families. And I think it is kind of redefining the overall everyday life of people all around the world. So that's also leading to COVID is leading to the impact on SDG achievement and development in general also. And I think will be known it'll actually be known in certain months to come by as to how much have we fallen back, or how much are we going to invest furthermore to be able to reach the development level which we were there earlier. But assessments do seem to be a little bleak as of now. What we also have learned during this time is that if responses are ad hoc, underfunded, and with a view to long-term goals, without a view to long-term goals, I would say, then the decades of progress that we have made will be reversed. We have made huge progress in health area in Punjab. But however, as a state of Punjab, I think as we begin to move now towards recovery, there is a coherent and comprehensive action we must put in place on a robust trajectory, if we have to achieve sustainable development. Now, there has been some researches which we have been undertaking world over. And, it's clear that public health and related issues, though pose immediate threat to human development in the long run, this threat will evolve into becoming very much to do with economic and environment, and they also have to come along with us. But our aim is to have this consultation in place so that in Punjab, we can look at how we can actually go for SDG push in taking care of COVID-related impacts. Now, why I'm saying that is because recently UNDP's international report, in partnership with Pardee Center of International Futures at the University of Denver, we got this report, and it examines the impact of COVID-19 on development agenda. And it also lays a potential pathway for socio-economic recovery from the effects of the pandemic. So the findings actually show that, while COVID-19 can lead to severe long-term impacts, but a set of ambitious but kind of integrated SDG investments can actually help the world exceed the development trajectory we were on before the pandemic. So even when taking COVID impact into account, if we continue with the SDG investments, if we continue to look at SDGs as that strategy to overcome COVID, then the SDG push is going to help us to come out of this really negative impact which we are facing right now. And on the basis of that, I thought if we are going to do the consultations, and that is the attempt of SDGCC to do consultations on all SDGs. And we really wanted to start with SDG 3 first, because if we are not able to look at health, because this consultation we are hoping will lead to many action points out of the health area also. And we can then put it all together and lead and share with other SDG consultations which are lined up every 15 days from now onwards. And I really, really welcome all of you. I really look forward to hearing from you and understanding from you how do we actually push the SDG agenda in SDG 3 in Punjab, and what kind of best practices and other interventions and strategies we can adopt from other states also. So another warm welcome, and thank you so much for joining.
Thank you, sir. Thank you so much. May I now request Shri Rajkamal Chaudhary, Principal Secretary, Department of Planning, without whose able guidance today's session would not have been possible, to please set the context for today's session, sir. Over to you, sir.
Thank you very much, Nandita. On behalf, and good morning to all of you. I feel very great pleasure on behalf of the Planning Department to attend this consultation for SDG's action plan for Punjab, with special focus on SDG 3, health and well-being. In fact, as we probably all know, Punjab was one of the first states to initiate action for realizing these SDGs, Sustainable Development Goals. The Punjab Vision document, which we have prepared, Punjab Vision document 2030, this has also been formulated for the state, in which the goals of the various departments, more than 30 departments have in fact are on board. These goals have been prioritized, and the steps have been taken to overcome the limitations of compartmentalized administrative setup. Because as we know that most of the government departments, everything appears to be as if, it's compartmentalized. So the aim of this consultation also is to work across the departments towards the achievement of certain goals which flow across these departments, and then only we can come to some sort of conclusion. There is a realization also that the individual sustainable development goals, 17 in all, these cut across these various departments. They cut across the schemes also, departments as well as their schemes. Therefore, this is very important that we should have a coordinated effort, which is being sought to be done today across the departments, if the goals and the targets which they have set for themselves are to be achieved. In this context, the Planning Department of Punjab has taken the lead in coordinating for the preparation of the 4-year strategic action plans, which is also a very important part of this whole process. And so far, more than 30 departments of the state have come and they have prepared this strategic action plan. Due to COVID-19 in 2020 and unfortunately still continuing in 2021, much of the efforts were not perhaps able to have been realized. And but we are in conjunction with the SDGCC of United Nations, UNDP, we are planning to have department-wise consultations also to help them or to see how much targets they have been able to achieve. The strategic action plans which we have made, they consist of course, indicator-wise baselines and then targets which are sought to be achieved by the year 2023. All these schemes of these departments, more than 30 departments, with reference to these sustainable development goals, these have been mapped and targets have been fixed for each scheme. More importantly, even the key performance parameters of the key personnel in these departments, these have also been mapped, and these would be reviewed from time to time to enable the department to achieve the targets. I'm very thankful to the SDG Coordination Center, UNDP, especially Shri Vikas Verma and his whole team. They have been really great help in helping us, helping the state in continuing to achieve the targets of these goals. So that is there. SDG metrics, I just want to flag one concern regarding the state. The SDG metrics for 2019, in which Punjab has scored a composite score of 62, which is no doubt slightly higher than 2018-19, but still it appears that the state ranking has slipped just 1 or 2 points in the all India level. And therefore, this is something which I would like SDGCC as well as the departments concerned to focus very, very, very carefully on this. There's a competition among states also, and much of the metrics, much of these scores, they are dependent upon the individual separate departments uploading their data and sort of being in touch with the whole system. So we would like that a special focus be done on this. And health department, of course, is a very important socially relevant department in which we have been doing very good on infant mortality in this reproductive and child healthcare. But in other areas, perhaps these things need to be a little bit focused so that we do much better in that. Now, as far as the health is concerned, this particular consultation is for the SDG 3, which is basically health and well-being. And I'm very happy that Honorable Principal Secretary Health, as well as Secretary School Education, is also here today, because as we said that this cuts across various departments. I'm very happy that so many stalwarts in the health department are here. The Director of Health System is here. Dr. Rajesh Kumar is here. Dr. Manmeet from the PGI is also here. Dr. Pradeep Joshi, and Dr. GB Singh is here. So this thing we need to focus on, that how the targets, the goals and the achievements of the health department in the final analysis with consultation, how we would be able to increase the composite score of the state, so that we come from, let's say, 10th or 12th position to even higher than that. Though in health, we are doing very well. I think we are in the 5th position right now, but we can certainly, with a little bit more effort, do much better than this. So with these words, and I realize that Shri Hussanal is very pressed for time, and he has to, he has to attend another meeting. So therefore, I will like to stop here and thank all the participants for participating. From the planning department side, any help or any assistance or any sort of thing from our technical people or statistical organization, we are always ready to help. And we would expect UNDP also to give us the full cooperation as they are doing. Thank you very much, and warm welcome to all of you once again.
Thank you so much, sir. Thank you for extending the support, and thank you for your guidance and setting the context. Thank you so much. As we go forward, I would again like to welcome our esteemed guest, Shri Hussanal sir, Principal Secretary, Department of Health and Family Welfare. Thank you for joining in, sir, and thank you for taking out time in these times where you're, as sir said, hard pressed for time. We are glad you could make it to this consultation. May I now request and invite you, sir, to kindly give the keynote address. Over to you, sir.
Thank you. Thanks, Raj, for, in fact, helping the health department in, discussing a very important aspect of healthy lives and the well-being, promote the well-being of the people, which is the sustainable SDG 3. In fact, if you go back, goal 1 and 2 also have bearing on the SDG 3. So when we are talking of ending the poverty, so what is our goal? Our goal is to ensure, health coverage to everybody. So we took a lot of steps in that direction, starting with the Bhagat Puran Singh Sehat Bima Yojana, and brought about 15 lakh families under this ambit. And taking it forward further, we expanded it to the Ayushman Bharat Sarvat Sehat Bima Yojana, which was coverage for the about 18 lakh families, but we added our own blue card holder families, the farmers, the construction workers, and small traders, and also journalists. So this number actually then it actually went up to about 40 lakh families. So as on date, out of about 58 lakh families in the state, 40 lakh have got an insurance cover of 5 lakh, across about 800 plus empaneled hospitals. So that has actually helped a lot. In fact, we were looking at the data, the insurance coverage which we have got from the insurance company, it is much more than what premium we have paid over the last 2 years. So that is one aspect. When we look at the next, goal of ending hunger, food security, improved nutrition. So there, we look at the data of under 5-year underweight children, stunted, wasted, BMI below normal, and also up to 5-year children which are anemic. So these, sections need a very, targeted approach to come out of these, indicators which are not favorable. If you are looking at up to 59 months of children which are anemic, the number at the all India level is 58%. And I mean, our goal is just 49.74%, which is again high, but considering the fact that a lot of efforts need to be, put into bringing these indicators under control. Having worked in the health department for almost 4.5 years, in my last stint, we did a lot of work in strengthening the health systems to actually bring about certain changes in these parameters. Be it the deliveries in the public hospitals. So the numbers went up dramatically in the last 3-4 years, and we were able to break the barrier of 50%, more than 50% deliveries in the public hospitals, and less than that in the private hospitals, with concerted efforts of having a maternal and child hospitals being bought in most of the district hospitals and in some of the sub-regional hospitals. That, to add to that, the free drug initiative actually did a lot of, turnaround, free drug initiative, and then free test and diagnostics. So these two things actually help the common man to approach the health services in the public sector. The home deliveries, which were about, about 10%, about 6-7 years ago, the number is now limited to about 1%. I mean, we have been able to bring about that change. Health-seeking behavior. People need to be, educated, need to be counseled to, approach the health services. So that what was required to be done? It was, looking at targeted population. In general, people would approach the health facilities, but if you look at the section which need the most, so these are the sections, the populations in the peri-urban areas or slum areas where the sanitary conditions, the living conditions of the rural development department, the school education department, the social security, women and child health department, because these departments are very much, part of the intersectoral approach to all this effort. If we want to actually have our indicators on a right side, they are favorable. I'm sure we haven't, we'll be able to do it because we consistently improving our IMR and MMR somehow for a year or so. There was something which somehow I could not, find out what exactly happened when some of the indicators did not go the way they should have. But we are trying to, find out what all went wrong, why the IMR actually, MMR actually, especially, actually increased rather than decreasing every year. So hopefully we should be able to, again, bring it down, because that's a very crucial element if we want to ensure that the health and well-being is our main concern. So the Department of Rural Development, Health, we were talking about the pandemic. Mr. Vikas has actually underlined the need to have this intersectoral approach, especially in view of this pandemic. We actually then came up with this idea of health and wellness centers. So the R is the first state which have operationalized more than 100% of these health and wellness centers as per the target given by Government of India. Leaving aside the target, I would like all 2,950 health and wellness center need to be operationalized. They have been a great support to us. In fact, in the latest attempt to arrest the infection being in the rural areas, we actually came out with this concept of health and wellness center being a pivot, which will cover the 3 or 4 villages which are attached with the health and wellness center. So that effort has actually brought a lot of positive impact. Our positivity has started coming down, especially in rural areas. We have surveyed almost about 1.6 crore rural population in about 12 to 14 days. I think in next 1 week, we should be able to cover the entire rural population, and we should be in a position to put a further stop on the infection. I think if you all know, the infection was as high as about 15-16% at one point of time. It has now come down to about less than 4%. Hopefully, it should continue to do so, but it has actually given us a lot of food for thought. What is required to be done to, strengthen the health services? Believe me, the department has actually chalked out a plan. One, if there is any anticipated third wave. Two, in general, how to strengthen our health services. We are coming out with more strengthening of the health systems. But today's deliberation would definitely help us in understanding this complex scenario much more closely, and the recommendations would go a long way in helping us to streamline our systems. With these words, thank you very much for bringing me on this platform. I'm happy I could share my thoughts, whatever I did in my first stint as in the health department, and now since last 9 months, I'm not doing anything except managing this pandemic. Little bit of non-COVID, but it is most of the COVID work. Thank you very much. Thank you, Raj.
Thank you, sir. Thank you so much. Thank you for highlighting the efforts and the work that's being done by the department, and that's bringing in a positive impact at the last mile, including the most vulnerable of populations. And thank you for pointing out to the areas of concern and the gap areas around SDG 3. Thank you for your guidance and inputs, sir. And we look forward to sharing a detailed strategic action plan around SDG 3, including the discussion points and action agenda chalked out after this consultation. So we look forward to inputs from everybody today. As we go forward, may I request everybody for a group photograph right now at this stage. If everybody could please switch on their video cameras, if possible. We would like to just, in this new normal, click a photograph just to commemorate the consultation. So may I request everybody to please switch on their video cameras, and if you could give us a good smile. Thank you. Thank you, everybody. Thank you so much. It's good to see new faces in this new normal. It's great that all of you could join us in. And thank you so much to all our dignitaries for joining in. May I request Dr. Manmeet Kaur? Yes. Professor Community Medicine and School of Public Health, PGIMR, Chandigarh, to carry out the panel discussions and take this discussion forward. Dr. Manmeet, over to you, please.
Thank you, Nandita.
Ma'am, please unmute yourself. Ma'am, you're on mute. Could you please unmute yourself?
Sorry, again, it was muted. Okay. Am I audible now?
Yes, ma'am, you are.
Okay. Thank you, Nandita, for this opportunity and calling me for introducing all the well-known people in public health. And but for me, it's very, very a kind of a privilege for me that I'm introducing and repeating the works that they have done over their lifetime and are still doing it. So this really is a big opportunity for me. So without wasting a minute, I have been actually asked to consider the time. So without wasting a minute, I would like to introduce all the panelists together rather than taking them one by one. And I will be starting with Dr. Sundaraman. He had been Executive Director, NHSRC. He is former School of Health System Studies, Tata Institute of Social Sciences. He had also been Professor of Medicine in JIPMER and is very well known health activist for health rights. Currently, he is a global coordinator, People's Health Movement. Our second panelist is Dr. Pradeep Joshi, who is working as National Professional Officer, Non-Communicable Diseases in the WHO Country Office for India since 2013. He is a postgraduate from the King George's Medical College, Lucknow. And as a public health professional, he is providing technical support to governments, both national and states, for strengthening national NCD program. Our third panelist is Dr. GB Singh, Director, Health and Family Welfare Services, Punjab. He is public health specialist with more than 33 years of experience. He has worked with WHO NPSP for 6 years, trained in health technology assessment, IIT Chennai, also quality in healthcare from USA, advanced course in vaccinology at WEC in France. He was a member of Indian delegation to Sri Lanka for revitalization of home-based records in immunization. He is resource person for WHO fellowship in FIC and ICD. He has been associated with development of national training modules and guidelines for NCDs. He has been state immunization officer, Punjab for 8 years, during which several new vaccines were introduced in the state. Our fourth panelist is Dr. Rajesh Kumar, who is Executive Director of SHSRC, Government of Punjab. He is Honorary Professor of London School of Hygiene and Tropical Medicine, UK. Also a visiting Professorial Fellow, School of Public Health and Community Medicine, University of New South Wales, Sydney, Australia. He is Associate Editor, Journal of Epidemiology and Community Health, and member of WHO Technical Advisory Group on Mother and Newborn Information Tracking of Outcomes and Results, which is known as MONITOR. He is currently member of National TB Operations Research Committee and HIV Technical Resource Group on Surveillance and Estimation. He has worked as Emeritus Scientist of ICMR. He had been Dean Academic and Head of the Department of Community Medicine and School of Public Health at PGI MER, Chandigarh. He obtained MD in Social and Preventive Medicine from Medical College, Rohtak, and MSc Epidemiology from London School of Hygiene and Tropical Medicine. He is a fellow of the National Academy of Medical Sciences. His areas of work include health service research, planning and evaluation of health programs, capacity building of health workforce, and public health informatics. And he had been probably a co-researcher. He has 40 research publications with H index of 62 and more than 22,000 citations. I think this panel is great for today's discussion. And I thank you all the panelists who could spare time to contribute today towards SDG 3. Thank you very much once again. And now I would like to invite our first panelist, Dr. Sundaraman. Dr. Sab, it's over to you. Thank you.
Thank you for this kind words and for this introduction. I would get right to the topic. I have, when I was asked to suggest a thing, I decided to take something that is very topical, but very much at the core of the whole challenge of sustainable development goals. Very often when we are talking of sustainable development goals, it becomes a lot of numerical assessments of progress. And at some point that has its own requirements. So you can't do away with it, but it has its own limitations. And we need sometimes to reflect upon the design of things we develop, much more so because the immediate context of health system, whatever we may have put under SDG 3, the targets, is really how we coped with the pandemic. And when we're talking of coped with the pandemic, we must even examine what it means. So we are really, I'm going to look at this particular challenge, which internationally is known as building resilient healthcare systems. If you see the SDG 3 has 9 targets, and after that it has 4 targets which are listed as A, B, C, D, which makes it actually 13. So these 13, the last 4 were added on, and it is interesting that the 13th target is strengthen the capacity of all countries, in particular developing countries, for early warning, risk reduction, and management of national and global health risks. This is a commitment that flows under the international, IHR treaty, the health that deals with health emergencies, international health treaty that deals with health emergencies and the control of pandemic, that at some point the preparation, the health system's preparedness to meet a pandemic is an important one. And though we are in the middle of the pandemic, many of these things should have been done much longer, much earlier. But even now, this challenge remains because we are not done with waves of the pandemic. And believe me that this century is going to face a lot more pandemics. The frequency with which pandemics are occurring has increased. And therefore, when we are looking at building health systems, we need to look at this characteristic of resilient health systems. Now, there are many definitions of resilient health systems. I don't want to bore you with the academics of it, but let's use a working definition that health systems reliance can be defined as the capacity of health actors, institutions, and populations to prepare for and effectively respond to crisis, maintain core functions when a crisis hits, and informed by lessons learned during the crisis, reorganize if conditions require it. And the clarification is made that this is not just an emergent property, but of a single, it's not some standalone, it's not some director or directorate that you create for that, but it is the way the entire system and its parts are designed. And at some point, this is what you mean by resilience. And the pandemic really is like a stress test, which actually brings out what a system is capable of. Now, there are conceptual and analytic frameworks. Again, I have been using much more Margaret Crook's framework, but I just giving this as a background information of how do you look at the ability of a system to respond to a crisis. And you look at the fact that, how is it placed within the ideological sphere? What is its legal and policy foundations? And how it is able to get information, respond to information, learn from what it is doing, and be able to self-regulate, change allocations, minimize disruptions, build in search capacity. It's a number of features. I used, based upon a whole lot of this background, we can actually pin it down like this because we are in the language of indicators. But we are looking at largely less disruption of social and economic life. So one requirement for me of a resilient healthcare system is a peculiar requirement that it's not only health that it handles, but the way in which you are dealing with the pandemic leads to less disruption of social and economic life. And we must remember this because there are many countries which have managed their pandemic with rather minimal disruption of social and economic life. Everybody has had, but relatively, the stringency of lockdown has been much less. And even what they call a very strict lockdown, maybe not even half as strict as what we did in India in the first few months. So that sort of lockdown, the point of building a system is that it can cope with the crisis without having to shut everything out. And close to it is that if you are going to preserve care for pandemics at the cost of other health care, that's also not a feature of a resilient healthcare system. And therefore, third, only I bring in the fact that the morbidity and mortality of the pandemic itself, one needs to be able to respond to it and learn and adapt to it. What did we do in the second wave that we learned in the first wave? What did we do in Kerala, which it learned from the Nipah virus outbreak or the earlier flu pandemics, therefore made them do a better job with the SARS-CoV-2 outbreak. So this sort of issues, if we had actually learned our lessons from pandemic in the first wave, we could have done much better in the second wave. And did we do that? Did our system actually allow ourselves to make such generalizations? Have we been able to do that? And finally, the issue of equity in the response and in the consequences of the pandemic. And when you look at what required, so those are the indicators, the preconditions are constant. You are not going to be able to do it without a certain deployment of financial and human resources. But again, given a certain degree of development of health systems, how exactly some states do better, some countries do better, a lot of this depends upon the characteristics that we draw from the matrix, the systems matrix, which is the organization of services and engagement, information, technology, human resources for health, financing, and governance. So these are the basic areas where we are looking to see whether the systems that we have is robust enough for that. Now, a point that I'm making is just strengthening what I had said earlier. Maybe this slide is not very clearly visible. The first column is cases per million, second column is deaths per billion. And we are comparing India, Nepal, Bangladesh. We are comparing like countries, very similar countries to us in the South Asian region. These three things in the first quarter, second quarter, and third quarter of the pandemic, starting from March. This is a measure of the strictness of the lockdown based upon the Oxford's school, public health school that has been looking at the different parameters. You can see clearly that India has the strictest lockdown, and comparably, even when the lockdown eases, it's a much stricter lockdown than, say, Thailand. Where Thailand, the stringency, the lockdown quotient is about 54, India is 91. In the second quarter, it's 55, we are 77. It's 56 in the third quadrant, and we are 77. So we have a much stricter lockdown. Same with, say, Sri Lanka, where its lockdown strictness is much less than what we have. But when you look at the deaths per million and the cases per million, these countries are doing far better than what we are doing. It's about 0.8, and I'm looking at November. We don't have figures for the current lockdown because many places the lockdown was incomplete. Now, to my understanding, therefore, Thailand had a more resilient care system because it was able to do a much lesser disruption of social services, of general economic life, in return for a much higher outcome on some of these parameters. And therefore, it is an important way of our thinking about it. So more resilient the healthcare system, the less the need to disrupt social and economic life, the less the duration and the intensity of social restrictions. So this is basically the point that we are trying to say, that it's important that we build healthcare systems that can cope with this. And one must understand that many have actually done so, learning from the SARS epidemic. So most of the countries that have done very well, China, Taiwan, Vietnam, to some extent Australia, Thailand, are all countries, South Korea, which faced the SARS epidemic, the COVID-1 epidemic, the earlier SARS epidemic, and learned from that. Of course, again, I'm making a simple point that there is a background on the preconditions. You do need a certain proportion of expenditure on financing and human resources and infrastructure development, without which you are not going to be able to make a difference. So again, let me put down the preconditions. Nations that spend more on health generally do better. That this has to be comparing likes with likes. You don't compare Spain with India. We'll come to that. Nations that have more financial protection, universal coverage do better. Nations that have higher densities of human resources for health do better. And nations that have more investment at all levels of care, not just primary care, do better. And within these subgroups, if you categorize nations by these subgroups, within them, design characteristics will matter. For the same amount of expenditure on of proportion of GDP that a country expends, the degree of financial protection they have, some countries do much better than other countries because there are certain design features that have made the big difference on them. But one point I'm going to make before I go further, and this is a point that we must remember regarding indicators. If you look at the best performers in India by IMR and MMR, and you look at their performance in COVID-19, you would see that most of them have much higher cases per million. Deaths per million, Kerala has done above the average. But most of the others have actually done worse than the all India average. Whereas the states which are traditionally, which are known as fairly poor performers in this area, tend to look better. I am making this as a caution. I'm not making this as a conclusion. I'm making this as a caution of how, when we read indicators, the indicators themselves are characterized by performance features. So the measurement of drug death rates, the measurement of testing rates, the ability to be able to capture the phenomena that is happening is very thing. And therefore, one could compare, as sometimes we made the mistake of doing, looking at, say, Italy or and saying, oh, India has got a much better performance than Europe. Not quite realizing that you have very different standards or achievement levels in the ability to health encounters and health incidences across these two places. So you have an entirely different situation over here that needs to be put in. And therefore, it is better to compare likes of similar degrees of development with each other to understand resilience. Now, resilience in low capacity systems, therefore, the design characteristics that can measure it are less disruption of essential health services, affirmative action to reach poorest sections, overcoming barriers in public health measures so that control is better, and in access to hospital care. So again, if you look at these indicators, then you get a better sense in being able to compare. And actually, you can compare across countries and within India across states using case study methodology. We have a paper that we published in a WHO journal, which actually does this to look at which countries had a greater resilience in measured in this way. And you can see that countries which had wider packages of primary healthcare systems, had much more manpower in the primary care area, were able to do their quarantine, contact tracing, which are the main public health measures. Masking and social behavior is secondary to that. At some point, your isolation and quarantine were much better done because you had people on the ground. Whereas places that did not have that staff would swear that contact tracing and no role once community transmission is there. It's a complete misunderstanding, but it is a situation that they are reduced to because anyway, you have been flooded out with the ability to do some sort of measurements. Similarly, the continuity of care, the ability for ambulance services, telemedicine, home delivery of services, some of these are important. Closer to community engagements which are there are important. And this very important concept called surge capacity. That when you build public systems, you don't build minimalist systems. You build systems with some built-in redundancy. So that when there is a disaster, it may not necessarily be a pandemic. It may be a train disaster in a local area. It may be an earthquake. It may be a flood. When there is a sudden increase in casualties, the public system is able to expand to be able to draw in. So typically in the older buildings, you will see the corridors were very large because they can be converted into wards very soon. And you can see that the public sector beds, because the private sector doesn't really lend itself for surge capacity, are actually what makes a big difference in your being care. And therefore, the strength of public service delivery has been important in it. The other big issue is information and information management, which is very clear. One of the important things is the way integrated disease surveillance and the health management information systems are integrated. In India, we had a reasonable IDSP functional, which was doing a fairly good job with flu pandemic management. But actually, from February, March, we let go of it, or it weakened considerably, and in fact, almost stopped functioning. Whereas the countries that did better, or we have case studies even from India that did better in being able to manage non-COVID essential services, were places which had systems in flow which could show exactly drop in immunization levels, or they could show a drop in, say, increase in malaria happening in a block where the malaria had been very well controlled. And therefore, they went there and they were able to integrate COVID control with malaria control. So a more decentralized use of information and an integration of HMIS with disease surveillance. And in fact, if we had such a system, we would have been able to contain the second wave much better. So where if you are testing only within hotspots, you don't notice a new focus of disease unless the disease has become much more expensive. So the cluster has grown very big. Whereas the countries like Vietnam or Australia that have done much better management, or China for that matter, have had very robust disease control systems that could pick up an outbreak early. It's not only the government part of it, it's also that there is no stigma, there is no denial in disease, people cooperate, they have a person whom they can trust, and there is a reliability of data. The other third characteristic has been good public health logistics and the ability to scale up domestic production amidst disrupted global supply chains. So in February of 2020, countries like Taiwan, South Korea, Iceland, to name a few, Vietnam, New Zealand, had already caught their biotech companies, given them the virus genome that had become available from mid-January, and asked them to create diagnostic kits. So when the pandemic hit their shore, they already had kits in place. Whereas we were able to have the first meeting reviewing our ability of kits one day before we declared the lockdown, well into mid-March. After that, we have done remarkably well in diagnostics. We have gone up from some 1,000 tests per day to something like 20 lakh or 2 million tests per day today. Our production has gone, we've become largely domestic production, and before we were 90% imports, we are now 95% domestic production, plus a very good volume of exports also in diagnostic kits. We have more than 20-30 manufacturers of diagnostic kits. So we had in diagnostics an ability to scale up. But look at, for example, what we did in vaccine, where we have a monopoly, where our scaling up has been a huge problem. So what is it that we could make diagnostics scale up on such a scale, but we didn't scale up. Whereas on oxygen concentrators, we are still desperately importing huge volumes of oxygen concentrators, where there is a relatively easier thing to build. It's not been possible to scale it up on the same way. Now, part of a system being resilient and intersectoral is being able to scale up. Because when you are talking of a world free trade and through that, all of it, or the whole vaccine supplies of the world, 70-80% of them have been cornered by the developed countries. Most of the supplies of the manufacture of developed countries have been consumed there. So before the understanding was on free trade, we could get it from them. But now only those countries which have the ability to provide their own manufacture have been able to survive that. And therefore, this becomes one important feature of resilience. Similarly, in health worker policy, I'm not talking not only on the numbers. It is about how caring the system is for the health worker, how the system supports the health worker, whether it is trading, precarious. And the more ancient and antiquated our health resource policy, the more authoritarian our mindset on that, the less modern it is in the way we deal with a modern workforce, the less the outcomes are. And some of these places which have done well have the best traditions in health worker management also. Finally, in governance, I'm not going into the entire area of governance, but there are 2 or 3 lessons that we can learn. One has been decentralization. I'm looking in Nepal in the way they did their, preserve their immunization without dropping. These are based on case studies on specific areas. And the ability to have systems where there is a feedback from online, ongoing concurrent research into decision making. And there is an affirmative action to reach vulnerable sections. And finally, the values that the government professes, the ethics, the legality, how sensitive we are to reaching out to the poorest people first, how we treat our migrant workers. The point is not that if we have to prioritize for migrant workers, but if our system can take care of migrant workers, then in that system, the middle class will get taken care of. But if you build a system that you have basically geared, like we see in this vaccine policy, towards addressing the needs of the middle class, then the 70-80% will not get catered to. So in some sense, the value systems that are held, which define a system, the affirmative action that is planned off, and the way is, these are some of the important things. Now, this is based upon a number of recent studies, published studies in this area, because we are in that particular area where we do operational work to actually inform decision making. So thank you. I didn't want to take too much time, but I wanted to just hopefully introduce you to the issues of design issues in making a healthcare system resilient. Because what we should learn from this pandemic is not only that we need a minimum amount of investment and in healthcare systems and public healthcare systems, but we also need them to have certain functional capacities, which may not be in use on a day-to-day basis, but are required in an emergency. But if they are in place, then you will be able to do better on your day-to-day basis. As the old statement goes, that you can have, how do you build, if your system cannot deal with one building collapse, how can it deal with an earthquake? Your system is designed to deal with an earthquake, then it can do a whole lot of other emergency care and even routine care on the way. So there is this particular learning.
Thank you, sir. Thank you very much. And the message is very loud and clear that make systems resilient, more resilient. The health system is less economic and social disruption will be there, including the health system. Very well spelled out characteristics and what we need to do to make our systems resilient. Those are great, sir. Those are great ideas based on the frameworks. And just to repeat few, that we need to spend more on health. We need to ensure the financial protection. We just cannot afford to go with the minimalist approach in the health system, and we have to have some buffer. Very well said, sir. Then we also need to have some access to technologies, have to have decentralized system, must have feedback mechanisms in place. And most importantly, to my mind, is that we need to have some values and ethics that we need to follow and ingrained in our health system workforce. Thank you, sir. We have a couple of comments and questions. Whatever you suggest, I think we can take them either towards the end or may start now. What is Navdeep ji or Nandita, what would you suggest? Should I take the or?
We can have our presentations all together, then we can have the questions.
All right. Thank you, sir. Thank you. Okay, now I would like to invite Dr. Pradeep Joshi. Over to you, Dr. Pradeep.
Thank you, Dr. Kaur. And Good morning, everyone. Hope I am audible. Yeah, okay. Firstly, I wish to congratulate the state government of Punjab and UNDP for organizing this conclave and express my gratitude for giving me the opportunity for the sharing the views on multi-sectoral approach to health. With the permission of the chair, I would like to present this topic in the four broad outline. First is on the background and the rationale for establishing the multi-sectoral mechanism. So as we all know, we live in a society where our health is determined by the various factors, which are social, economic, and cultural factors which shape our health, and also the quality of life as well as the health risk factor outcomes. So that is the main reason behind having the need for the multi-sectoral action or the approach. The multi-sectoral action is not a new arena or phenomena in the health. We are being practicing from the past, whether it is due to the HIV epidemic or any zoonotic disease outbreak, or to say for the maternal and child health conditions. And recently the example being the COVID-19 pandemic. So it is not new arena, but with the actions have become now more pronounced with the changing epidemiological transition, where the lifestyle disorders have taken the most of the burden. With the frequent, like Dr. Sundaraman have just mentioned, with the frequent outbreaks of the emerging and re-emerging diseases due to the climate change, and with the growing antimicrobial resistance, the multi-sectoral mechanism is very much required at this point of time. But before going to the further into that, we first understand what is the difference between the multi-sectoral and inter-sector form of cooperation, because these words are used interchangeably. So multi-sectoral cooperation or collaboration is basically the whole of government approach, where the health, the two government agencies or more than that government agencies come together for certain actions or activity. In contrast to that, intersectoral cooperation is basically the linkages between the three critical sectors, which are private sector, which are government, civil society organization, and the private. Broadly, we call as a whole of society approach. Why we need this type of multi-sectoral collaboration? So I'm taking example from the non-communicable disease, because we are discussing on the SDG 3, and 3 out of 9 outcome targets of the SDGs are for NCDs, non-communicable diseases. So it has that relevance. So if we don't take actions, the cost of inaction to the middle and low income countries is around $7 trillion. While for this health promotion and the preventive measures, the cost of action is just 170 billion. So that is why, if in the terms of the things, we require the multi-sectoral actions. Is the multi-sectoral action so important? We can understand from the recent UN high-level political meeting, which was done for the NCDs in 2011, where this word was referred for more than 15 times. And in compared to the earlier UN high-level political commitment on the health, which was only for the HIV/AIDS in 2001, the reference was given to only 2 times in the entire outcome documents. And this reference for this multi-sectorality and intersectorality is being repeatedly emphasized in the upcoming documents of all the, whether it is universal health coverage or antimicrobial resistance or even vector-borne disease control program. So that gives them. What is the rationale? Why we need multi-sectoral approach? So first, it modifies the social and economic determinants of behavior. So it influences how the people will eat, how the people will drink, or practice their healthy lifestyles. Second, the health sector cannot do alone. So it creates an enabling environment to initiate and maintain those behavior changes in the community and individuals. Third, it can impact multiple risk factors simultaneously. Take an example recently from the school ambassador program, where through the school department or education department, most of the risk factors for the NCDs can be taken at one go. They are cost effective, as in the earlier example I have shown that if there is a political commitment, it is very easy to implement, and it takes relatively short time than the management and other perspective for the prevention, and moreover it has intergenerational benefits. What kind of the multi-sector policy interventions we are talking about? So if we divide into two broad, which are relatively hard and which requires most of the interventions or most of the collaboration are, first is the fiscal measures, which are taxes and subsidies. Second is the regulatory measures, which we called as law, rules, and directives. The other one is relatively easy to implement, which is information and communication, mainly the campaigns and labeling, and any structure like building enabling environment or creating an infrastructure for that sake, like for the physical activity part. So what are the how we should proceed for the multi-sectoral actions or approach for that? First, we have to establish the need and priorities, and this should be based on the evidence and the current requirement. And SDG targets or SDG targets and the goals are the guiding where we should start or prioritize our activities. Then we have to understand the actions based on the policies and programs which are already there. So analysis of the existing policies and programs based on the priorities which we have identified need to be identified. And then the third step is to where to implement this kind of action. So is there any supportive structure or process available? Like if there is a coordination committee or a parliamentary committee or steering committee, that kind of supportive structure is existing or not. Then the next step is doing an assessment, whether we are doing that action is going to make any impact. So the health impact assessment and then subsequent engagement with the other sectors is required. And like any other program, monitoring, reporting, and accountability a mechanism should be there. And nevertheless, the last point, without building the capacity of the other sectors, it cannot be done. So how we should proceed, like step by step. So first we have to identify which the key agency or key sector having high influence on policies, equity, and health outcome will do. Then generate evidence on that impact. Then start the policy dialogue as a third step with the intersector partners or the concerned partners which have the outcomes. Then develop the shared goals, which are win-win situation for both the sectors or the multiple sectors. So it has a mutual benefits and doing those multi-sectoral actions. I'm again things which I have earlier shared in the slides, taking an example how one sector has been identified and how to take those actions. I'm just giving an example for Ministry and Broadcasting, and the issue is about the indirect advertisement of brand sharing and brand stretching, which we are usually known to. And the other one is about the reducing the exposure of the sugar sweetened beverages and foods high in fat, salt, and sugar. So these two actions, what are the policy options which are available? Has been mentioned. There is a program advertisement code under Cable Television Network, or during under the Press Counseling Act, there is a provision where we can further take an action to prohibit all form of direct and indirect advertisement. Second example about the fiscal measures where the financial services can play a role. There is investment by the insurance companies into the tobacco industry. So that can be easily discouraged through the investment. There are other fiscal measures which are taxations and other things which I am not touching right now. So what is kind of right mix? Actually, it requires me to implement multi-sector action, the right mix of capacity and skills. So first we have to understand the politics and its context, like which are the divergent sector or convergent sectors for those actions, whether there is any commercial drive, like alcohol taxation is one of the cost-effective intervention to do. But the argument being presented is like, if we increase tax on alcohol, people will switch to the lower cheap variety of the alcohol. So we have to understand those commercial drives and whether how the power influences. So whether we have to understand whether the healthcare is driving the multi-sector action or not, in comparison with the Ministry of Finance or Ministry of Home Affairs, whether the health sector has that prominent role to take the action forward. And most importantly, the action, whichever we want to do, is based on the community need. The skills are required. This is basically on the advocacy, mediator, and enablers. And it is a kind of art. It's not a science like a technical document which you can do. And there are complex issues which requires intensive discussion and require coordination of the whole of the society or intersector response. To summarize what we have learned so far is basically we have to look for the opportunities, building the partnership and trust with the other sectors, win-win situations, and then the participatory process to monitor the impact assessment. There should be an accountability process, and now moving beyond from the public sectors to involve other civil society organizations and private sector as well. Sharing few examples from the international as well as national. So first is about the Thai Health Foundation, where it has been established under the Prime Minister, and the Minister of Public Health is the Vice Chair, and there are other departments who represented there, followed by there are independent experts and the consultative committee. So this is established by the Health Promotion Foundation Act, which has its funding from 2% what the surcharge they levy on the alcohol and the tobacco tax. So it collaborates with all sectors and society and do multiple kind of actions which are related to tobacco, alcohol, substance use, road safety, health promotion plans for vulnerable population, health system strengthening, community health promotion in other settings like workplace settings, school settings, and healthy media systems. So this kind of activities is being done through the Thai Health Foundations. In India, we have this National Multi-Sector Action Plan for Non-Communicable Diseases, where the coordination mechanism has been clearly defined. There is a standing committee of secretaries, which is chaired by Cabinet Secretary. It takes the inputs from the Interministerial Committee, which is chaired by the Secretary Health. And there are nodal officers from different departments who provide inputs. There is a technically advisory group, and other sectors like civil society, private sector, UN agencies provide their inputs to the health promotion or the mechanism which has been chaired by the AS Health. Another level, the subnational example is about the tobacco control, where there is a national level coordination committee. There is a parliamentary committee which looks after the COTMA implementations. And then there is at the next level, there is a state level coordination committee, which is the chief secretary chaired that. And there are 14 departments. Main role is enforcement, monitoring, and IEC. And below that, there is a district level coordination committee where the district magistrate is chaired with the 12 departments. And the main role is awareness generation and in media campaign and enforcement of COTPA. And through this multi-sectoral mechanism, the key achievements in the tobacco controls are, we have a COTPA Act and subsequent its amendment. We have newly this prohibition of electric cigarette bill in 2019. There is a tobacco taxation which is gradually increasing over the period of the years. Large pictorial warning on the tobacco products, which covers the principal display area of more than 80%, tobacco-free schools and institutions, and alternative livelihoods for the BD rollers. I'm just giving a more broad example how this the National Multi-Sector Action Plan for NCDs are looking for these 4 risk factors which are key for the measure of the mortality and morbidity in India, and how this different policy options at the national level plays important role, whether it is smart city, whether it is school, whether it is Make in India, whether it is Khelo India or National Rural Livelihood Mission, Ujjwala Yojana. So every policies of other sectors contributes towards the reduction of the risk factors, which eventually will reduce the overall mortality and morbidity from the NCDs. So towards the end, I just want to highlight there are multi-sector actions and policy options which doesn't cost anything to the government or doesn't require any other resources. One is taxation, which is on tobacco, alcohol, and sugar sweetened beverages. Advertisement restrictions or banning about that. Public health smoking, banning the public health smoking. Regulation of the processed food, especially on the salt and the trans fats, which are major contributor to the non-communicable diseases. Proper pack labeling of tobacco, alcohol, and the foods which are high in fat, sugars, and salt, and replacement of transport from the cold chain. What are the barriers for the multi-sector actions? One is there is a lack of awareness. The information gap is there. The other sector doesn't know how the actions of there will play a major role in the disease contribution. The second is lack of interest. It doesn't concern to me. The sector are already occupied in their own transaction of business rules, so they don't care about what is of their interest. Territoriality, that who are you to tell me, that the power game, which is barrier to the multi-sector. Financial control, who have the control to spend the money, and the lack of coordination, that who is in charge. These are the main barriers. So in summary, the multi-sectoral actions are possible at the country and the state level. So the process is, first we have to identify what mechanisms are available at the state level or national level, and then define the process through which we will engage the other sectors. And definitely there are tools available for the health, for the multi-sector approach for health, which are participatory intersectoral tool or health impact assessment tool or policy auditing tools. We can use this, and not only use for the NCD, but for the other disease conditions as well. That's all from my side. Thank you. Thank you so much.
Thank you, Dr. Joshi, to bring home the point of whole of health approach and highlighting that health promotion is really very, very important. A very good example from Thai, and they have health foundation under Health Promotion Act. I'm not sure that we don't even have the Public Health Act. So probably we have a long way to go. But certainly we can always make a beginning, and we can make a beginning at the state, at the national level with whole of health approach, like involving all the other sectors as well to contribute to health of people. Thank you very much. Now I would like to invite our third panelist, Dr. GB Singh. Over to you, sir.
Good morning, everyone. I hope I'm audible.
Yes, sir. Very well.
Thank you so much. Thank you. Any discussion about the Sustainable Development Goals, or what we are to achieve, what way we need to proceed, would be inadequate and inappropriate till we talk about the Millennium Development Goals. We have worked on that. We have been following. We have been working on these Millennium Development Goals for almost 15 years, starting with the turn of the millennium, with very clear-cut guidelines, with very clear-cut goals that we had to achieve. Of course, the Sustainable Development Goals, they go much beyond that, but they have definitely been built upon the MDGs. When we look at the MDGs as such, how far we were able to achieve them and how far we were able to progress towards the achievement of our Millennium Development Goals, that still remains to be answered. Of course, I would definitely say that during the process, if I talk about the state of Punjab itself, or if we talk at the national level as well, we have been able to achieve a lot. The reduction in the infant mortality, reduction in child mortality over these years, then reduction in the maternal mortality, then universalization of healthcare services, improvement in maternal health, and combating the communicable as well as the non-communicable diseases. Yes, we worked a lot on all these aspects. But then when we look at the achievements, when we look at what we were able, whether we were able to achieve our goals, no, we were quite far from them. So these sustainable development goals, they do give us another opportunity, a good window period for achieving all those goals and targets, for providing good health to the community. And at the same time, it gives us an opportunity to develop our healthcare systems. As Dr. Sundar Raman very rightly pointed out, that is our healthcare system resilient enough to respond to the needs of the time, to respond to the emergency conditions where we are looking at the pandemic like COVID. So during the last 1.5 years, we have seen that there were some instances where the system has definitely faltered, but at the same time, we had some strength as well. We were able to take care of the patients and appropriately and at appropriate time. We were able to mobilize our resources in the shortest possible time. We were able to get our experts. We were able to get all kinds of HR, whatever we required at any level, right from primary to the tertiary level. We were able to mobilize our resources. We were able to take care of our patients in such a manner that to keep our mortality at the lowest as much as we could, as well as improving the recovery rate of the people or the patients who are suffering from COVID-19. At the same time, this was the period, again talking about the resilience, it was the time when there was we were afraid that the general healthcare services, the non-COVID healthcare services would be affected. Of course, there was some effect, but again, I would say that we were able to continue with a lot of non-COVID activities also during the period. So in the sense that we tried to take care of our patients of communicable as well as non-communicable diseases. We were able to provide all the maternal and child healthcare services, COVID as well as non-COVID pregnant women. So yes, all these activities, we have been carrying out all of them, and we have been taking care of our cases or taking care of our population as such. Talking about the Sustainable Development Goals, and that also specifically for the achievements in health, what we need to do in future, what we need to, how we need to proceed for the coming years, because now that we are coming into the last decade of the Millennium Development Goals, or we say that we have already done about 5 years of work, and in the coming 10 years, starting from 2021 till 2030, what we need to look at is how best we can improve our healthcare systems so that we are able to take care of these situations like the pandemics, which we might face in future. This is a pandemic of the communicable disease I am talking about. But at the same time, we need to look at the invisible pandemic, that of the non-communicable diseases, which are rising at a much larger pace as compared to the communicable diseases. the communicable disease, they can come and go. But the non-communicable disease pandemic, which we are looking at and which we need to be scared of, that has to be taken very seriously, and then we need to develop our healthcare systems, as well as I would say we need to look at the other SDGs as well, which are going to be of much greater importance and much greater help to the healthcare system for a reduction in the non-communicable diseases and to make us capable of taking care of all the patients that are going to develop over the coming 5-7 years. The way the pandemic of the non-communicable diseases is building up, we are going to face problems in the coming years. And for that matter, I would say that we do need to look at all the different sectors. We need to look at the education sector. We need to look at the R&D. We need to look at the global partnerships for all these conditions. We need to look at the responsible consumption and production of the materials, the affordability of individuals, the financing mechanisms. All these things that need to be taken into consideration for us to achieve these sustainable development goals over the coming years. The challenges of gender equality, the challenges of hunger and poverty, they are definitely going to affect the achievement of these sustainable development goals, even for the health sector. So we need to look beyond health sector. It's not only that we are developing our hospitals, that we are developing our primary, secondary, and tertiary healthcare services. We need to look beyond all these to achieve our sustainable development goals. As far as the health sector is concerned, there has been a lot many discussions. There have been a lot many people have been talking about creating a public health cadre at the state level, but going beyond, we need to have a strong public health care system. We need to have a strong public health cadre all over the country, so as to have a comprehensive thinking process, to have a comprehensive policy making process in public health, so that we are able to achieve our sustainable development goals. No doubt, when we talk about the healthcare system itself, of course, the National Rural Health Mission, then of course the Urban Health Mission, and now the NHM, they have played some important role in achieving this, in working towards these goals. But what we need to look into now is the emphasis on the peri-urban areas, where all sorts of diseases, whether communicable or non-communicable, they are on the rise, and those are the areas where we really need to put all our efforts. So in a nutshell, I would like to say that one thing more that Dr. Pradeep Joshi pointed out, that we need to build partnerships like the public-private partnership. But at the same time, I must caution here that it's not that we bring in the private sector into the healthcare delivery system, then the government can do away with this responsibility of providing the primary and secondary and tertiary healthcare at all levels. So yes, involvement of primary healthcare system, involvement of private healthcare system is important, and we do need support from the private, whether it is through the clinical care or through the partnerships with the private players in other modalities. But the role that the public healthcare system or the government healthcare system has to play, that has to improve further, that has to be a much more important role to play in the overall delivery of the healthcare to the community, as well as for the achievement of the sustainable development goals. So I must say that while we are working towards SDGs, we have to take care of all the other sustainable development goals as well, so that we are able to achieve our goals in the healthcare system with the involvement of everyone, every other system, every other modality, and taking along all the other departments, taking care of all the other organizations, whosoever and whatsoever can involve in the provision of these healthcare, in achievement of these healthcare goals. Of course, taking care of the financial problems of the community, of the patients, of the families who are, where the people are suffering, where they are unable to take appropriate treatments, whether it is through insurance or through the community financing or through other systems. That also needs to be taken care of, needs to be included in the overall planning for the achievement of the Sustainable Development Goals. So with this, I would end my talk just with the last comment that we need to bring everyone together. We need to take everyone along for the achievement of the Sustainable Development Goals, and we need to work together for this purpose. Thank you so much.
Thank you, Dr. Singh. I think we moved from global to national and now to the local, which is Punjab. And very well said that hunger, poverty, gender, and rising NCDs are the big challenges for the state as well as for the nation. And we need public health cadre, that's true. We also need to actually work together, as Dr. Joshi and yourself are highlighting. So we have to take the multi-sectoral action plan ahead in Punjab. Thank you, sir. Thank you very much. Now I would like to invite our panelist, Dr. Rajesh Kumar. Over to you, sir.
Good afternoon, everyone. Dr. GB Singh has highlighted what Punjab has done and achieved, and what is has been planned for future. So I will also share my views on what needs to be done. So I have few slides. Let me first try to project these slides. Okay. I hope you can see my slides. Can you
Yes,
see my
Visible.
Yes, sir.
Visible.
Okay. Okay. So from my perspective, the health system in Punjab, one can view it as a glass half full or 2/3 full, but still we have gaps in it, and we always strive to be the best. As our principal secretary also mentioned, that maybe we have achieved a lot, maybe 60%, 70%. We are maybe 5th in the country as a state, but I think the desire in everyone is to excel and to reach a stage where we say, and we are proud of that, we are number one. Punjabis always try to be number one in everything, and health is a field which is very close to the heart of people, and we would like to be number one in this. So my presentation would be targeted on the gaps which we still have and which we can bridge with some effort. So I will touch upon 9 aspects in my talk briefly, and I'm not going to give you any data, but these are some ideas which I will propose in front of you. The first thing is, what is the current situation in Punjab, where we are now? In Punjab, the private sector dominates in the curative services. This is a fact. Various surveys, NSSO, and even in the COVID crisis now we have seen, predominantly this is being looked after by the private sector. And private sector is also not very uniform. It ranges from clinics to corporate hospitals, for profit, not for profit, and a large group of informal practitioners in villages, in cities, in every mohalla, neighborhood. But our public sector dominates in the preventive care. And in the public sector, we have Department of Medical Education, which looks after tertiary care and medical education. Then Department of Health and Family Welfare, to which I belong now. It has a Punjab Health System Corporation, looks after the secondary care, district hospitals, sub-divisional hospitals, few community health centers. And then we have National Health Mission, which you are all familiar, is more geared towards primary care. And we also have a state health authority for social insurance. And there is another Department of Rural Development, which has rural dispensaries. This is looks after primary care. This is very unique in Punjab. Some years back, the primary healthcare system, the rural dispensaries, subsidiary health centers, they were transferred to Rural Development Department. But now gradually this is being taken over by the health department also. Now, in this scenario, we have very high out of the pocket expenditure, one of the highest in the country, in fact. And public spending on health is low, like many other states. Punjab also does not spend adequate amount of budget on health. And this all leads to low financial protection. You know, the admissions, hospital admissions cost highest in Punjab as compared to many other states. And it leads to catastrophic expenditures. People have to spend more than 20% of their income on health. And as I mentioned, there is fragmentation of services. There are several vertical programs, and SDG has also targets around many vertical programs. But here I will cover only, the health system. Health system is the basis which contributes to all the programs. So we need somehow to weave these programs together in the health system. And of course, we have a primary healthcare system which is quite weak as compared to other counterparts like tertiary care and secondary care. Therefore, and another weakness in our system is, health system is, we are concerned about disease, treatments, some bit of prevention, and that to clinical prevention, but there is very little advocacy for health promotion and public health. That is another issue which was highlighted by Dr. Joshi also. Now, our focus, although there are many targets of SDG and within this goal 3, but I think to my mind, this universal health coverage is the most important one. And this is illustrated very nicely by this cube, that we need to see that population covered and different types of services. And what we see in Punjab, we have the social health insurance, Sarbat Sehat Bima Yojana, which at the center level is Ayushman Bharat, and our principal secretary referred to it. It already covers nearly 70% population in Punjab. But I will point out that, the 70% is covered, but 30% is not yet covered. We need to find some mechanism by which this 30% is also covered. If we feel that they are the ones who can contribute, maybe companies can offer some, they can buy some and pay some premium. Some methods, we need that. There is some voice.
Can you please mute?
Please mute yourself.
Please mute.
Yeah, it's okay now. I think another thing is that this covers families in the private sector as well as government sector. And people are free to avail services. But the point is, government is already investing in government sector. If that is not utilized and most of the care is provided by the private sector, this brings in inefficiency in the system. So one has to look at how we can optimize this and see that services which are not available in the district or in the government institutions, private is empaneled for those services. So that we can provide more services in the given budget to the people. And then there is a cap of 5 lakh per family per year. So this does not cover many conditions because there are packages. We saw in the COVID period that COVID patients who are admitted, if we go by these packages, it was only a very small sum of money which can be reimbursed by the patients. Big gap was for conditions or for interventions which were not covered in this social health insurance. So we need to have a look at it and make it more people friendly so that the coverage becomes almost 100%. Another aspect is cost sharing and user charges. You remember in 80s and 90s, World Bank advocated these user charges and cost sharing. And Punjab also had a project of World Bank. And since then, this cost sharing and user charges is going on. It's a small amount of money as compared to the budgets which state spends on health. But this collection of this small amount of money deprives some people from availing services. Now, my point of reference here is all those who are at the margins of the society, the migrants, the rickshaw pullers, daily wagers, farm workers, for them, and in fact, these user charges have been done away with in many other countries. Another thing is that in OPD and IPD, our services are free, but people have to buy medicines and diagnostics, and these are not covered by insurance. So one has to see that how these medicines and diagnostics, either they come in the ambit of social insurance or mechanism by which these are provided to people. And same is for many preventive services also. For example, vaccines, we still do not have HPV vaccine, and even the COVID vaccine, some people have to buy. It's not free to everyone. So these are certain gaps for universal health coverage in Punjab. We can look forward to meeting these gaps. Now, then another piece is comprehensive healthcare. Our communities in the rural areas, very widespread, and in the urban areas, there is urban outgrowth. We need to have this hub and spoke model of PHC with health and wellness center. Now, this PHC, whether it should be a mini PHC in this hub and spoke model, or it should be a block PHC. Earlier, we have this block PHC serving about 100,000 population, and this mini PHC serving about 25,000 population. And this health and wellness center, which is, as was mentioned, Punjab is now #1 in the country in establishing health and wellness center. But now we have to see that how these are operationalized to provide all kinds of services. earlier our NHM or NRHM was more focused on RCH services, to some extent on communicable diseases, but non-communicable diseases were not a big part of the program. So how we can have a comprehensive package which covers all kinds of the services? And this primary healthcare won't be successful. We need support of hospitals at the secondary and tertiary level, as well as public health, because it is not only curing patients, it is preventing diseases also. Now, while designing a system of primary health care, the biggest problem is human resource management. Health is one department which has the largest human resources, I guess. Maybe education department also has a very large human resources. So managing this human resource is one of the challenge. We need recruitment policies, remuneration, placement, transfer, promotion, contractual versus regular. There is a lot of discontent that, same job is being performed by a person who is having a regular salary, much more than what a contractual staff gets. And repeatedly people have expressed this kind of issue. So someday, it is not a issue of 1 day or 2 days. People are working for last, 15 years, 20 years, this kind of situations. So someday someone has to solve this problem. So I think human resource management is one big piece which we need to work on, and better to have a personal management information system, a electronic database. A beginning has been made in the NHM for this, and we need to make it more functional. And somebody raised a question in this panel discussion also. Some of the participants have said that how to meet the human resource needs, especially specialist doctors in the hospitals. So one of the ways which has been initiated by in few of the district hospital is to have DNB program, creation of residency positions, and especially if we can create residency positions in family medicine, then perhaps over a period of time, we may have more specialists within the health service, not only of family medicine, but other specialties also. And in community health centers, there is a acute shortage of specialists. Actually, there are 5 positions of 5 types of specialists. And as all of us know, that one specialist in a health center cannot make services stable. So instead of having one pediatrician, one surgeon, one obstetrician, they also have to go on leave. So services never become stable. So it would be better if we can have multitasking at this level, having 4 or 5 or 6 family medicine doctors who can handle problems at that level. And similarly, at the primary health center also, we need to have not only one medical officer, but 2 medical officers, so that services are stabilized there. People know that whenever we will visit primary health center, there will be some doctor to attend to us. And even 2 doctors, 1 doctor can be on tour, can visit health and wellness center, conduct OPDs there on some days, so as to give confidence to the community health officer there and to the community. So this type of arrangement perhaps can instill more confidence among the staff as well as among the people for utilization of our primary healthcare services. Now, appropriate technology is also very important for primary healthcare, and we need a lot of logistics to make our services better. Drugs and surgical supplies and diagnostic reagents, we need a continuous supply. We have an electronic system in Punjab now, and we need to strengthen it further so that up to the last institution, which is sub-center or health and wellness center, there is a continuous supply of medicines and reagents so that services do not suffer. And similarly about the equipment, we can have an electronic inventory. Already we have a contract with some agencies who do the repair, but these are some of the areas. Like now, point of care equipments are available for lab, for biochemistry, microbiology, even molecular biology, very handy and equipment which can be even installed in the community health center or even a primary health center. These labs as well as X-ray, ultrasound, cold chain, these are necessary and these are must for primary healthcare also. Now another piece is data management. We need to have digital system. Right now we have multiple stand-alone databases by Government of Punjab as well as Government of India, and there is very high, recording and reporting burden on the people. Like we have e-hospital, RCS portal, Nikshay, NCD portal, IDSP. There are many like that, and many times the data has to be entered again and again. So we need a integrated health information system, at least for primary health care, which is open source. We need not spend a lot of money on the software, open standards, and with API, it should be interoperable so that the information can be transferred to any other system at ease. And another thing is we need to link medical records with community health information. Our OPDs as well as the information which comes from the homes and outreach, everything has to be integrated into this system. So this will reduce our burden on the staff, as well as this will provide data for evidence-based policy making. Now, public health infrastructure is necessary. We have seen in this time of COVID for disease prevention and control. We need public health units at the state, district and block level, and also public health lab. We have public health lab now in every district. But if we can have labs at the block level also, because it takes a lot of time to transport samples from the field to a tertiary care hospital. If we analyze, how much time it takes for RT-PCR results to come right from sampling to result, the most of the time is in transportation of the samples from one place to another place. So it will be better if it is close to the community. And we need public health workforce which is properly qualified, like MD community medicine, MPH, and even Bachelor of Public Health also at the lower level, at the block level, at the PHC level. So we need to have this public health infrastructure. And finally, we need a State Public Health Act. Actually, a Punjab State Public Health Bill has been formulated by the department, and it has been circulated to all other relevant departments in the state. It is in the discussion to provide a protection of rights in relation to health and well-being, including those related to all the underlying determinants of health for achieving universal health coverage. Dr. Joshi mentioned about intersectoral coordination, but we do not have a forum or a mechanism where discussions of this type take place. Even Dr. Sundaraman mentioned this resilient health system. So we need a lot of inputs from other departments also. So the proposal is to have a state public health board, which is chaired by the chief minister, and health minister is the co-chair, chief secretary is the secretary, and at least all the relevant departments are represented here along with experts in public health, representative medical and paramedical associations and non-governmental organizations. So this type of a board can plan all the activities and also monitor and evaluate. And similarly, for decentralization, we need a similar kind of setup at the district level. Now, finally, whatever we do, we need to be accountable to people. and a strong system of monitoring and evaluation is needed. Even for SDG, as was mentioned right in the beginning, that we need indicators and data for those indicators to compute and see that where we stand. So we have in the health system public health standards, which were declared in 2012, although it is time to update those standards. But so far in Punjab, we don't have any institution which has, which we can say that qualifies to these Indian public health standards. So for the next 10 years, I think 2030, we need to achieve Indian public health standards in most of the institutions. And quality of care, not only in public, but private health institutions. Now, private health institutions, the Clinical Establishment Act has been passed by Punjab, and it can be utilized further to see that there is price control for drugs, diagnostic and services. At least prices are displayed transparently to the public. And then both private and public institutions, they should make some annual reports, and they should be in public domain for people to see that what are the outcomes. So there should be some role for the local bodies also, Panchayati Raj as well as the municipal authorities in monitoring and evaluation, because the Finance Commission has now dispersed some funds to them also for investment in health. So it is a good time to involve them into health activities. Another aspect is research and development, so that we can innovate, try to do more with whatever little money we have, and plan it in a way that our outcomes become better. So this accountability is another piece which we need to work on, so that we achieve finally the right to health or health care, whether we have SDGs or not, but we have in our state our own vision and our own policies so that we achieve right to health. Finally, in summary, I would say that we need more investment in the public sector. We need a very strong primary healthcare system using this hub and spoke model. Recently, department has recruited hundreds of medical officers, and there is a plan to have all our primary health centers functioning. And we need to have this human resource management and some system by which we can upskill, have multiple skills, and even create and train specialists within our system. And this logistics for medicine, diagnostic equipment, this will be necessary to optimize our resources, and data management with digital solution will lessen our burden on the workforce, and they can devote more time in service delivery. And public health units for disease prevention and control, I need not emphasize, anymore. It is obvious to everyone. And for governance, the state public health bill, if planning commission can also contribute into this, improve it, and maybe push it to the administration. And this can provide a forum for all the departments to come together and work for health. Monitoring and evaluation of outcomes. We measure our outcomes as Dr. GB Singh mentioned, IMR, MMR, so many indicators we monitor ourselves, but it will be better that if our elected representative at the local level, they also monitor and evaluate our outcome. That will be good for all of us. So with these words, I would like to thank all of you. I wanted to highlight some of the gaps, and before me, Professor Dr. GB Singh and our Principal Secretary already mentioned that what we are doing, and already we are at a stage which is more than average for any other states of the country. But in our desire to become better, I think we are proposing these few ideas to all of you. Thank you very much.
Thank you, Dr. Rajesh, and for providing actually the not only identifying the gaps, but providing solutions that how to fill these gaps I think all these are doables and we can do it provided we have finance, we have money to do it. So I think the biggest challenge is to actually bring more money into the health system so that we can improve our human resource, we can use technologies, we can go for multi-sectoral action, and all those things can fall in place if we have more money, I think. I don't know, after hearing to all the panelists, the one thing that is coming to mind is that certainly we need to increase the financial health of the health system. So once that will improve, then probably health and wellness will be achievable for all the states, more importantly for Punjab. There are some questions and comments which I would like to actually present to all the panelists for their responses. But before that, I must thank all the panelists for coming up with brilliant ideas to achieve the SDG 3. Thank you very much. So let us start with the questions. I think the first question was raised for Dr. Sundaraman, and it was like, one minute. Non-COVID services, especially MCH, have suffered during the pandemic. When we have a health crisis like COVID-19, how can we balance the healthcare service between COVID and non-COVID patients? So this is for Dr. Sundaraman.
Thank you. There are 2-3 questions which I can take off and help make it faster. One is, of course, this problem of how does one maintain non-COVID essential health services in a pandemic. One must look at the multiple pathways by which non-COVID services are compromised. One is the fear in the public itself to come to the hospital, a lack of information of how to come, barriers to coming due to the lockdown. This is a set of issues which blocks the public. Then there are certain provider sort of issues, including administrative shutdown of services. So sometimes the services are shut down by the administration per se. And sometimes it is because of infection outbreaks and doctors not being well, etc., where in some sense it's a bit more preventive. But the good news is actually that there have been people or dedicated professionals in at different places who have been usually these are professionals who are very passionate about their patients. They talk in terms of, I couldn't let my pregnant women, my women go, who will take care of them during such situation? Or we have made we have struggled and brought down malaria into a world achievement in 5 years. Now it was reversing. And driven by that passion, they have actually come up with very innovative ways in which they are able to maintain that. I have one very good case study from Biratnagar in Nepal, where they actually ran the services together, and some from Orissa in Malkangiri, Kerala. And the basic issue is that at some point you have to work out a way of integrating both services, being able to provide, for example, in malaria, when they are doing fever testing or when they are testing fever for COVID, they also test for malaria, and vice versa. And they found 5,000 more cases of each when they were testing. But there is also very good nosocomial infection control in the outpatient, where you really need to have streaming systems which are done. These are all documented in one paper that I was referring to, that where you have this particular thing. And there has been a pulse survey, 2 rounds of pulse survey conducted by WHO at looking at the way these are compromised. And you can look at that. So the broad message I can say is that if you go to the details, if there is a determination that we cannot let go of non-COVID essential services, then except perhaps in a very peaking point in about a week or 2, beyond that, one should be able to sustain all services effectively. And that requires good information inputs. It requires these things. So there is a number of things that are required, but one should learn from the way it has been sustained. And the point I was making is that that is one of the big indicators of whether your system was resilient or not. A closely related question is that how does one measure the impact of actions in non-health sectors on health indicators, the social determinants of health? This is not an easy question, because actually there are claims that about if you see one state having a better health indicator than another state, the social determinants of health may contribute 70% to the difference. The actual strength of the health systems and their performance may be contributing only 30%. This is from a Commonwealth Foundation Fund figure, but this is approximation. Now, so it's not a very easy thing to actually attribute to specific actions of health sector. For example, on gender equity, or if there is an equation on education, what impact does it make on healthcare, or say on indoor pollution control, or the switch to switch in cooking gas, what does it difference it makes? Fortunately, there are a few large surveys available, and I'll refer you to the India Human Development Survey, which is done between the University of Maryland and NCAER, with a very large sample size, which actually lends itself and has been designed to do just this in a quantitative sense. Qualitative ways are a bit problematic in this to be able to attribute. And actually, there is therefore a technique where it can be done, but it is sort of expensive and time consuming. So they have 2 rounds of surveys, 2005-06 and 2011-12. And based upon the companion longitudinal data. So you can get that. You don't have very good other longitudinal surveys, but one other survey is the last survey, whose data is not yet in the public domain. The longitudinal aging studies of India, which come 40-45, but incidentally capture all of these social determinants in the determinant. So my point is only it can be done. And on the question of national vaccine policy, I go much into it. I completely agree that with the Supreme Court general direction that it has to be a single price, and largely for most nations in the world, even the most privatized nations in the world, have been able to provide vaccine at very subsidized costs or free to its entire population through systems which are either publicly run or under public supervision. And we require that, and we are capable of doing that. So even if we revert to our February 28th policy as compared to our policy, we will be reaching it. The point we've made in the Supreme Court case, where I'm also one of the petitioners, is that at some point that it is in breach of a vaccine policy that you already have. And I think that it is important that we take this responsibility in a much more serious way. I think that's the main questions that were directed to me.
Thank you, sir. Now, Dr. Joshi, there are some questions for you, probably one. How does one measure the impact of actions in non-health sectors on health indicators? And what are the indicators and methodology? If you can just shortly explain, because it's a long question. I know the answer is quite long, but.
Yeah, so I will just briefly touch upon, there are tools available for assessing the impact of the policies and programs of other sector on the health. One of the most commonly used that tool is the health impact assessment. So that can be done, and it can be done as a part of their, which we have already doing, is environment assessment. It can be included into that one, or can be done separately as a social impact assessment or integrated impact assessment. So that is the most convenient tool which we can use to measure the impact of the policies or the programs of non-health sector on the health. Taking again the example of the non-communicable disease, as I have earlier mentioned, which contributes to more than 59% of the premature mortality. There are best by interventions which have been outlined, and that all these actions depends upon the action of the non-health sector. And there are being measures which have been identified and which have shown also that the policies are making those impact. Just take for an example for the tobacco taxation. So the tobacco taxation, it has been clearly evident that it can reduce, every 10% tax increase can reduce the tobacco consumption by 2.5%. And that is well evident through the surveys which the health department does, the global adult tobacco survey and other things. The other thing is about the recent study about the one of the very cost effective measures which I have mentioned about restricting the advertisement. So that has also shown the impact, that how when we do the subsequent survey, whether these questions can be included in the ongoing National Family Health Survey, or there can be other standalone NCD survey, where you can assess the impact, whether the children's or the adults have seen those labeling and what was the impact. Taking again from the example from the global adult tobacco survey, where there is a policy option where they measures the impact of the different policy options under the COTPA, how they are being impacting, or where the tobacco consumption prevalence. So there are tools, and although it is a complex thing, it's not so easy to measure the impact, but the health impact, if we want to measure the health impact assessment tool, is the most convenient tool to start with. I hope I was able to answer the query. Thank you.
Okay, thank you. So there are two questions for Dr. Singh. The first question is, how do you plan to bridge the gap in human resources within the health department? And this was felt during COVID-19. Dr. Singh, is he there? Okay, no issues. I think we can, if anyone else can answer this question, or should I proceed? Yeah, please. Yeah.
I think Dr. GB Singh might have left because there was another meeting, important meeting where.
He's there.
No,
he
I am very much there, sir. I am very much there.
Okay, then you take up the question.
Take up the question, please.
Sorry, please. Can you repeat the question?
Yes, sir. What is the plan to bridge the gap in human resources in health department in Punjab, which was acutely felt during the COVID-19 crisis?
If we look at the HR situation in the state, over the last 1 year in particular, and over the last 3-4 years since this present government has taken over, there has been a lot of recruitment in the state. We have recruited more than 3,000, nearly 3,000, added almost 3,000 HR in the department. The most recent one was the induction of 250 general duty medical officers, that is MBBS doctors, into the department. Apart from that, we are conducting walk-in interviews regularly, almost once every month. This month we have 2. One is on 5th of June and another is on 19th of June. So then apart from that, Baba Farid University has helped us recruit pharmacy officers, staff nurses, MPW female, laboratory technicians. So almost every category of staff has been recruited in the department during the last 1.5 years. So and we are continuing with the process. Whatever seats are falling vacant due to the retirements, or due to the people who are either resigning, or due to the death of some unfortunate deaths of our staff members, we are filling all those posts on an urgent basis. At the same time, we are also in the process of restructuring the department with the induction of more posts. So we are expanding the department, which is happening after a long interval now. So with this, I can definitely say that over the next 6 months or 1 year, the department would be there would be a totally changed department would be visible. And I don't think that we have any dearth of staff as of now. Of course, there are some specialties where we are facing some difficulties, but then they will also be overcome. Not much issues in the on the HR front at the moment.
Okay, sir. Another question is for you. If you can, 2-3 minutes more. What is the status of implementation of the Clinical Establishment Act in Punjab? How many private hospitals have applied for registration so far?
We have another meeting for Clinical Establishment Act today. So we are in it is almost ready and we are in the process of implementing it pretty soon.
Okay.
So once it is accepted and done, then of course we will start getting applications from the private hospitals.
Right, sir. Thank you. Now Thank you, sir. There are 3 questions for Dr. Rajesh. The first one is about rural dispensaries. Are rural dispensaries in Punjab being converted into health and wellness centers?
As mentioned by Dr. GB Singh, there is a process of restructuring going on in the department. A review is going on. Not that all rural dispensaries are converted into health and wellness center. It's not like that. It is being reviewed that, all the earlier sub-centers, they are being upgraded to health and wellness center. And in some places where there were like these rural dispensaries, in some places, it is a case-by-case review, I think, where sometime they feel that it will be better to have a health and wellness center, and some will be retained. So it's in a flux right now. There is another question about this Dr. Simranjit Singh from Seva, that women have anemia and this is a problem. And so this is correct, that anemia is quite rampant in Punjab also, as in many other states. And this has been taken up as one important problem for our Department of Social Security also. This is Women and Child Development. Malnutrition, undernutrition as such is a problem. There had been some improvement in childhood undernutrition. Actually, compared to last NFHS 1 and now if you see last NFHS, there has been a decline in the stunting, which is, the heights have improved. And I think Dr. Manmeet can tell more. She is a principal investigator of a project trying to find out that in this height improvement, how much is the contribution of other departments vis-a-vis health, because there has been contribution of many other departments in this aspect. So same way, anemia is also a nutrition related problem, and maybe multi-sectoral action is needed for this rather than the medical approach of giving iron and phosphate tablet only. So there was another question which says that what is the status of primary health care in Punjab? I included that in one of my slides for this very reason, that this is the aspect which was needs more attention. Because of the shortage of staff, many times doctors from the primary health center, they were put on emergency duty in the community health center or in the SDH. Even during the pandemic, when cases were much more in the urban area, and health infrastructure in the urban area is not that much, so people were withdrawn from the rural area to work in the urban area. I think we need a good primary healthcare infrastructure in urban as well as rural area. And this recruitment which Dr. GB Singh referred to, it has been decided by the government that they will be placed in the primary healthcare, and there will be in the restructuring many more posts of emergency medical officers for the SDH, DH, and those are being proposed. So the additional manpower is being proposed. Any other question, Dr. Manmeet?
hub and spoke model we have already covered, I think. There is just one last question, and it is from Dr. Sundaraman again, and it is about how much impact does the size of population affect service delivery? Thank you, Dr. Rajesh, and over to you, Dr. Sundaraman. Yes.
It's an interesting question, because we do know that large countries struggle with delivery, but it's really not about size, because eventually you can look at each state as comparable to one other nation. You can say, okay, Punjab is comparable to New Zealand, and you can have the same population size, and New Zealand can do this, Punjab can do this, and you can look at even GDP comparisons. Punjab would be very close to the GDP, I think, of Vietnam. So in some sense, why are we? So, and eventually you have your administrative unit, and you have your, in fact, there are strengths to it. The problem really is of iniquities. When you are managing a central thing, the differences between different people to make sure that there are people who are not left behind. The different areas, but so you can have iniquities between states, you have iniquities within states, you have districts that fall behind, districts that, and the challenge of addressing iniquities becomes much larger, because any central, however decentralized you are, and the more decentralized you are, one of the residual functions of the center, suppose we have a situation of ideal decentralization. We are far from that, but suppose we have that the states can manage and districts can manage their own. Then what is the residual function of the central force? The residual function is to manage inequity, because not all the states will come at the same rate, not all the districts will come at the same rate, and the center has to make sure that those who are poorly performing are enabled to pick up. So if you decentralize, you can manage, but you will still be left with the challenge of iniquity, on which we do a pretty poor job. That's really where the problem of population comes. And at some point, some large areas get left behind because we have not managed that particular standards of that. That's not been easy. Whereas if they are autonomous of that at some point, then you deal with them differently. So, but it's not. Eventually, it can be the administrative unit can be to a size which is comfortable, and you can actually work on that. And there are big countries that do well, so it's not a limiting factor. Thank you.
Thank you, Doctor. And with that, I think we are quite close to closing this scientific session. But before closing, I must thank the Principal Secretary Health, the Principal Secretary Planning, for giving me this opportunity, along with, of course, our Regional Director from UNDP. Thank you so very much for providing me this opportunity to actually moderate this scientific session. And I found this session very, very interesting and useful. Thank you very much. And with this, I close the scientific session and hand over to Nandita. It's over to you. Thank you.
Thank you. I'm sure all the participants will agree that this was a super engaging and a very, very rich discussion. And thank you, Dr. Manmeet. Thank you for so eloquently engaging everyone and moderating the session so well. Thank you so much. I'm sure everybody will join me in thanking you in holding the session so well. I think we're almost there. Before we close, I would request Mr. Navdeep Gautam, my colleague, to kind of summarize today's session, give the pointers for way forward.
Thank you, Nandita. It's a privilege to be part of this session, and we are thankful to the Principal Secretary Health and Principal Secretary Planning and the thematic experts on this issue. I will take only 2 minutes to summarize, keeping in view the timing. So we started the session with the introduction that regarding the SDG 3 and importance in the COVID phase. So we, as our regional head, Mr. Vikas Verma, pointed out that we have entered the critical decade of action in the backdrop of COVID-19 pandemic, which has added to the challenge. So the SDG push is very important for this. And then our principal secretary planning showed that how the state has worked on the SDGs, especially the preparation of 4-year strategic action plan and coordinated efforts by all the departments for achieving the SDG, especially in the 4 years by the 2020-30, set targets have been made, and that we are going to achieve with the effort. And then Principal Secretary Health and Family Welfare clearly highlighted the gaps in the system and also the achievement of the system, that how we were able to reach the last mile. Special mention of urban health kiosk and other health and wellness centers, and with a special focus on the urban and peri-urban areas. Especially the director, Dr. GB, has also mentioned that we are able to cover the rural under NRHM and urban under urban health mission, but there is a continuum from rural to urban, where the peri-urban development is going on there, and there are many unauthorized or the structures or the coming up of the new slum areas. So the integrated approach, especially of local government, the rural development department, and the Department of Education and other, is very important for this. And in the scientific sessions, it was a privilege to listen to the stalwarts, Dr. Sundara Raman, basically focusing on the resilient health system in the time of COVID, that how we had gone and how we could have gone with a minimum disruption to the economic and social life while handling the pandemics, and learn from the previous crisis. And this pandemic, this is not only the COVID, the pandemics may be more. So how we have to manage our systems, the system may have to be resilient to look into all the other services, especially during this phase, and the capacity building of the systems. And then Dr. Pradeep Joshi very rightly highlighted about the multi-sectoral approach to the health. So whole of the government, as under SDGCC, we are talking about the whole of the government and whole of the society approach, that if we have to achieve the SDGs, it is not only the one department or one sector which have to work. It is a multi-sectoral approach which we need to look into it, and so that we are able to achieve the SDGs, and also the enabling environment and cost effectiveness of different initiatives which we have. And the very important examples, like the regulation of advertisement of demerit goods and the multi-sector policy interventions which were discussed, and with the examples of the Thai Health Foundation, and also the measures which government can take without any additional financial burdens, that is banning the advertisement and taxes on the tobacco, alcohol, etc., and the ban on the smoking and the labeling and other such initiative which can be taken. Then Dr. GB pointed out the journey from Millennium Development Goals to the Sustainable Development Goals. It's a real challenge for the state that we are able to achieve on the most of the health indicators, but the maternal mortality ratio is a real challenge which we are facing, and the silent killer or the silent diseases, the non-communicable diseases which are approaching. If we see the shift from the 1990s to 2015, the global disease burden study also highlight that especially in case of Punjab, we are able to reduce hypertension, about the for the state, the hyper out-of-pocket expenditure, then the low public sector expenditure. Even if we see the last report of 75th NSSO, it has clearly highlighted that we are amongst the top in the out-of-pocket expenditure, that is more than 30,000 in the average. And even in the public health system, although we are providing the free diagnostic and free services, but the out-of-pocket expenditure is more than 30,000 per hospitalization here. So these are are things which needs to be looked into. And the important and very interesting thing was that how to cover the 30% remaining population. It may be the contributory insurance or maybe another set of the system which state needs to look into this. The human resource is a real challenge. If we see based on the data, around 44% of the positions of the specialists are vacant, or moreover, especially in the case of gynecologist and pediatrician, that's a real challenge for the state. And even at the SDG level, what we are focusing is that the data is very important for evidence-based planning. So the Dr. Saab has rightly pointed out the integrated platforms which are based on the APIs or other systems which are need to be. There are n number of platforms or the n number of dashboards which are running. So we need a consolidated dashboard where we can look into the achievements as well as the gaps and the evidence-based planning can be done. And lastly, the session on this question and answer and the panel discussion was very, very, very important for us, that we can get the questions and the answers from the experts. And it is very important for our SDG action plan that at the community level, because in this the participation is from the community level, academia and other institutions. So this was a very important session and very learning session for us. So with regional head, Mr. Vikas Verma, thank you, sir.
So thank you so much. First of all, I think an excellent consultation. I cannot emphasize enough that we've got so many action points which we can include in the SDG 3 action plan. And thank you everyone for all the learned people and our officials who participated in that. And I want to congratulate my team of SDGCC and especially Navdeep Gautam for able to organize it in such a comprehensive way. And the only 2 points which I'm so delighted to continue to hear back again and again, which one Mr. Subramaniam at the starting itself talked about in terms of let's build the system for marginalized people and not just the middle class, because I think that talks to the heart of SDGs, which is leaving no one behind. And I think if we do that, we'll be really able to have a very comprehensive and a robust kind of health systems available for everyone at the right cost. The second thing, which again came again and again and was talked by Dr. Pradeep Joshi about the convergence, the integration, the multi-sectoral approach, which is again one of the cornerstones of SDGs and cannot emphasize enough that how important is that. And the fact that there was talked by Mr. GB Singh to strengthen the public health cadre, and it's already happening in Punjab, which is so heartening to know. I think more we need to go ahead in the public health lab area available at the block level and other things came out. And lastly, I want to talk about this integrated health information systems. And I want to share with all of people out here in health and otherwise that UNDP has been at the forefront of creating all these systems like you are seeing CoWIN, which is nothing else but a reflection of eWIN, which we have already created for all the states all across India. And CoWIN as a site, as a program was integrated with the eWIN, which we have done. So we have a lot of expertise in that, in creating tools and information systems. And we would definitely like to take this discussion forward as to how can we be of any help to the Punjab government in creating many such systems in place, even at a pilot basis or otherwise. And with that, I really want to thank all of you for making this particular consultation very, very special. Thank you so much, Mr. Rajkamal Chaudhary, sir, and also to our Mr. Hassan Lal, sir, who could attend this meeting. I have seen you throughout being here, and many of our directors who are deputy directors who are also part of this. Really wonderful. Thank you so much, sir. And we'll continue to see you in the next SDG action plans consultations, which we are going to have, sir.
Thank you, sir. Thank you, everyone, for joining in.
Yeah, thanks.
Thank you. Thank you.
Thank you so much.
So we are wrapping it up. Thank you.
Thank you. Thank you.
Yeah, thank you. Thank you so much.
Thank you very much.
Thank you so
Thanks.
much.
Thank you, Doctor. Thank you. Thank you.
you for all.